There is some clinical situation in which we need to know more about the case in order to be able to reach a proper decision based on sound diagnostic evidence. In this aspect, we might need an advanced imaging technique.
I guess you are talking about CBCT. Ladies and gentlemen, welcome to the episode number 14 from Endocast, hosted by Francesca Charuti. Hi, Francesca.
Hi Ahmed, and by Ahmed Shauki. So today we are going to go through the indication of CBCT in endodontics. First, we need to know what is CBCT. So CBCT is an acronym for cone beam computed tomography, which is a valuable imaging tool in dentistry because it provides us with a three-dimensional visualization of the dental structure, and it can enhance our capability of making a correct diagnosis first and then a treatment planning, because sometimes with a bidimensional image we can just guess what is happening with our patient's tooth. Look at this center incisor. I take a bidimensional x-ray and I imagine that there are few resorptions on this tooth, but when I take the actual 3D image with a CBCT, I have a more comprehensive view of what is happening with that tooth. And so I know more about what I can do for the patient because she cannot get an implant with that kind of bone, for example. And so I have all of my list of options for the treatment planning. Even if you see on the other projection, you see that there is some problem with a tooth that has an endodontic treatment, but I can do apical surgery there. And then we have this like Swiss cheese tooth in which I have to try a completely different approach. And that's where CBCT can really help us in choosing what to do for the patient.
Yes, I totally agree about that. It's a very valuable tool to get to know what's inside. So, if we need to get a reference for the indication and uses as well as the potential benefits of CBCT in endodontics, we always get back to the European Society of Endodontology and the American Association of Endodontists guidelines and position statements on the use of CBCT in endodontics. So, Francesca, regarding the first and most important indication that really makes a difference between the 2D imaging and that imaging tool, the CBCT, let me ask you, is it possible to detect early stages of apical periodontitis or periapical lesions on conventional two-dimensional radiographs?
Well, not every time. Above all, if we are talking about maxillary molars, because due to the superimposition of structures, even if we take a very nice preoperative x-ray, we might not be able to see the signs of early periodontitis. In this case, for example, I was guessing there was some problem because I was seeing a slight widening of the periodontal ligament space. I was guessing that there was a missed anatomy, a missed MB2 canal in that upper molar, but only with the CBCT I could be sure. And I could tell the patient, well, there is a lesion, there is a missed canal. But in most of the cases, the conventional x-rays are inconclusive because they don't allow us to see the whole scenario.
I totally agree because you cannot just slice every section on the 2D radiograph, so you will not see inside where something is born. So, how about complex root canal morphology?
Even in this case, sometimes bidimensional x-rays cannot help us. Of course, they can give us an idea of the outline of the roots, etc. But sometimes we can face some particularly strange or anomalous anatomy. So in that case, I think that a CBCT can be the game changer in our treatment planning, because we can know how to treat the tooth before putting the rubber dam on and starting drilling the tooth. This is, for example, a case by Andreas, who found a first upper molars with one root and one root canal, which is extremely rare. But he was able to diagnose it and to be aware of the situation only by taking the CBCT. So I think it can really help us as endodontists, because we face some challenging cases, and with the CBCT we can be prepared on what we have to find.
Yes, exactly, and that's why we always say to our colleagues and in lectures or congresses that CBCT is a minimally invasive tool for discovering the anatomy just before, as you said, placing even the rubber dam. So sometimes we have some teeth that cannot be saved, like those with vertically fractured roots. Our CBCT are indicated for those cases.
Well, yeah, but you don't have to think that you can always see like the fracture, because you can see it only in cases in which the fracture is huge. For example, in this case, the tooth is split in two. So yes, I can see the fracture, which I could not notice from the X-ray. From the X-ray, I could only see that there was some problem. But to assess the nature of the problem, of course, I had to investigate more. Some other times you cannot see the fracture, but you can see some signs associated with the fracture, like some bone destruction on the side of the root, for example. And in some other case, you don't have a clear situation even with the CBCT. And so the quickest and most effective way to exactly know what's happening is to raise a flap and go see yourself with a microscope what is happening. Sometimes you still have to do that. What do you think about this?
Yes, I agree. To sometimes the crack is so small that it cannot be detected by the maximum resolution of the CBCT machine that you are using or the scan setting that you are using. So I think in 2012, and it is included in the book 3D Imaging in Endodontics, there are certain signs that despite you are not seeing the crack on the CBCT, you can have some signs that they say they are highly suggestive of indicating a presence of a vertical root fractures. And let me give you some of those signs, like when you're taking a CBCT scan, and of course it can be of the high resolution type. So if we have a complete loss of the buccal cortical plate in all sections. So this is highly suggestive of the presence of a vertical root fracture, especially in previously treated tooth. Also, the presence of an apicomarginal defect that extending from the marginal bone and along the side of the root up to the apex and around. So this is a second highly suggestive of vertical root fractures. Also, if we have thinned cortical plate, widening of the periodontal ligament space in all aspect on one side of the root, mostly will be on the buccal side, that is also highly suggestive. And the last one is very interesting. When you have a large post in one of the root canals and you have a radiolucency inside the bone opposite to that, the end of that post, so that is another indication for the presence of a vertical root fracture. Those signs are highly suggestive, not necessarily concluding 100% about that, but they give an idea about the possibility or the high possibility, and they can be present all together in one tooth or one by one. And apart from the vertical root fractures, CBCT can also help us to determine the size of the inflammatory internal resorptive defects, whether perforating or non-perforating, which will reflect on our treatment decision and treatment plan, whether to be a surgical, non-surgical, or combined approach. Similarly, in invasive cervical resorption or external cervical resorption, CBCT can help us in a very important thing, which is a classification of the defect in terms of height, circumferential spread, and the possible pulp involvement. And this classification, which is stated, by the way, in the latest European Society of Endodontology position statement on resorption, can help the clinician to categorize whether this tooth can be saved or not, and how you are going to treat that resorbed tooth. And that's why we need to have CBCT in those specific clinical situation.
Yeah, because of course you don't want like to try and see what happens without having some certainty about the outcome. So I do completely agree. And of course we don't have to forget one very common indication, that is the evaluation of a previously treated tooth that has been unsuccessful. So maybe we can see the reason why there is this persistent infection. We can see if there is some missed anatomy, as in this case, typical upper molar with missed mesiobuccal tooth canal. And so, of course, CBCT is extremely indicated in these cases because it can help us seeing the quality of the filling, the maybe the mishaps that happened during the previous treatment, etc. So it can be an extremely valuable tool in these cases.
And how about the use of CBCT in pre-surgical planning? I know that we discussed this before with a lot of our colleagues, but we have to say that because it's one important indication.
Yeah, of course. CBCT can be extremely helpful in these cases because it can help you planning the surgery with a good margin of safety. I mean, you know in advance which is the size of the lesion, for example. You know in advance if you are going to end up close to some very sensitive structure like the maxillary sinus, the alveolar nerve, etc. And so, according to that, you can plan your flap, you can plan the osteotomy, you can plan if you have to use, for example, piezo surgery or you don't need it. You can choose to adopt a guided surgery approach or a freehand approach. I mean, you have all this information that can help you a lot in just trying to have everything planned first in order to have the least of accident in between the surgery. So I think it's a very good tool to have.
I totally agree with that. This is very, very important, as you said, for a good safety margin during surgeries. But we don't forget also that in traumatic dental injuries, in which there are major luxations like extrusive or intrusive luxation, sometimes in avulsions, root fractures, and alveolar fractures, CBCT is indicated according to the most recent updates from the International Association of Dental Traumatology guidelines in 2020, so that it can help us to determine whether those fractured teeth are deemed not savable, or we can just save them, and in some instances how can we reposition luxated teeth, or we can fix some alveolar fractures. So traumatic dental injuries is one important indication in CBCT scan uses. These were in brief the most common indications for obtaining a CBCT scan. So now, Francesca, can we summarize the benefits versus the limitation of our CBCTs that we use in daily practice?
Of course. Well, of course, the accuracy, because a three-dimensional scan can be extremely more accurate than a conventional bidimensional image. And then we can see the anatomical structures in a better way. We have an improved vision. And also, you have to say that this is a non-invasive instrument. So we can do it without harming the patient, because the dose of radiation that we give to the patient is extremely controlled. And nowadays, with modern armamentarium, we can just have a very good quality image without irradiating the patient a lot. And so, of course, this can be helpful in our clinic, and it gives us detailed cross-sectional images. We can watch the patient from every aspect, axial, sagittal, etc. And so we can have all the information that we need. And last but not least, there is some article that says that even experienced clinicians change their treatment planning when they were able to see a CBCT instead of a bidimensional X-ray. So this is very important because it means that it can enhance our decision-making process based on evidence. And so I think this is one of the most important things in our practice, because at the end of the day we are treating patients and try to provide them with the best treatment. And so the more information we have, the better we can work. That's it. Talking about limitations of CBCT, we said it before. Of course, it gives the patient more radiation than a conventional X-ray. But let's think about what we had to do in the pre-CBCT era. Maybe we had to take 3, 4, 5, 6 different angulated X-rays in order to guess what was the problem. Nowadays, with just one image, a CBCT, we have all the information. So I think that yes, it gives a higher radiation dose, but it's completely worth it. And of course, if you want to have a CBCT in your practice, it costs. It costs you money. It's expensive. And so it can be a problem. And also because one thing is I have the CBCT in my practice. So I have a problem, I take the CBCT and then I watch it immediately and I solve immediately the problem with the patient. Another thing is that I see the patient, I had to send him outside or elsewhere for a CBCT, and then I reschedule the appointment and then I discuss with him, etc. So it's about ergonomics. It's an investment that one can make, but it might be worth it. And then, of course, there are some potential artifacts that can affect the quality of the image. Let's think about for example, the quality of the machine, which is used for taking the CBCT. There are very different machines with different images and different qualities, but also the conditions in which we take the CBCT. If the patient has some crowns or bridges or implants close to the area that we need to watch closely, we might have some scattering, so we have to know it in advance. And we have to maybe plan everything in order to reduce as much as possible the scattering. So if I know that I have to replace a crown, I put a provisional crown before and then I take the CBCT in order to have less scattering. And then, of course, we need to be able to read the CBCT. And so we have to study a bit and get used to that kind of image in order to be able to get all the information that are there for us, but we need to know if we want to see them.
Yes, that was a good brief about the benefits and the limitations. We cannot say disadvantages because it provides us with a lot of advantages, but it can be somehow a limitation. And a limitation can be solved in the future. We don't know. In conclusion, we have to say that CBCT is a wonderful tool, but every scan has its own limitations. So it's not there is no perfect scan. So as Francesca said, that we have sometimes scattering metal artifacts that can compromise our visualization of the details, as well as we still have resolution problems in the currently available CBCTs, even with a high resolution. Also, we have to send a message to our colleagues that every scan has to be justified. We cannot just do a CBCT scan on regular basis in easy cases that can be visualized using conventional two-dimensional radiographs. So if the CBCT scan has no impact on the diagnosis or decision making or the treatment plan or the prognosis of the case, so I think this is considered to be an over treatment or something that's not needed. In the end, we have to get used to the tool before we use that tool, because you cannot just have the tool without be having the experience to use it. Do you agree with me?
Totally, totally. And I think that we should remember the as low as diagnostically acceptable principle. I mean, you have to provide a patient with the lowest dose of radiation that actually helps you taking a decision about his tooth and his health. And of course, we need to be trained, because if you and I get to drive a Formula One car, probably we are not making the record at the first lap.
Of course.
But give us time, Ahmed. Give us time, and I think that we're going to
Yeah, we will
surprise.
get the F1 car later.
But jokes apart, one of the most important things I think for our colleagues is to see how CBCT can really help them in the clinical practice. So, if you agree, we might ask one of our friends to help us in the next episode. What do you think?
Yeah, that would be good, just to give a different point of view from his or her own practice. So that would be good. I totally agree with that. So, guys, stay tuned for the next episode with our guest about CBCT. See you later.
Bye.